Carmelina represents a previously understudied population is shown by this slide. One could see that the percent of EGFR less than 60 in SAVOR, EXAMINE, and TICOS is much lower than what we have in Carmelina. However, I don't want you to leave with the impression that this was a study of patients with only advanced renal disease. Indeed, on this particular slide, you see the distribution of renal function within Carmelina. Indeed, 37% of individuals had an EGFR of greater than 60. But this is the population that's never been studied effectively with respect to a DPP-4 inhibitor cardiovascular outcome trial. Now this particular graph also illustrates the difference between Carmelina and other DPP-4 CVOTs. And what you see here on the y-axis is baseline EGFR, but we also plot here percent macroalbuminuria. The other trials clustered together, whereas as you could see, Carmelina is different in that respect. So very unique population that is often a difficult therapeutic problem. Just let me comment on the quality of the trial. As you heard, 98.7% of patients completed the study, and 99.7% of patients had vital status available. Remember, as pointed out by Darren and the other speakers, the cardiovascular and kidney outcomes were adjudicated. Particularly important to remember that heart failure was a pre-specified adjudicated outcome. So again, let's compare the Carmelina results with the other CVOT DPP-4 inhibitor cardiovascular trials. And here you see again the 3-point MACE. They are extremely consistent. There's clearly no signal for any benefit or harm with respect to 3-point MACE. However, when we look at hospitalization for heart failure, there's a 27% increase in the SAVOR study. There is perhaps a signal with EXAMINE. TICOS is right on the line. And now you have Carmelina, which is to the left of line of unity, clearly no signal of an increased risk of hospitalization for heart failure. When we look at the microvascular outcomes, it's important to remember that Carmelina was unique because this was pre-specified. And we see that indeed, as mentioned by Bob Toto, the microvascular outcome was mainly due to the difference in albuminuria progression. I think it was actually Vlado who mentioned it. Sorry, Vlado. So, key safety findings. No new safety findings for Linagliptin were identified. There was a numerical imbalance in bullous pemphigoid and acute pancreatitis, which was known from the established class labeling. Total cancer cases were similar across treatment arms, and there was no increased risk of hypoglycemia, including patients most susceptible for hypoglycemia because they have reduced EGFR and they're on insulin. To summarize, in Carmelina, Linagliptin demonstrated cardiovascular safety in a clinically relevant population of patients with type 2 diabetes, cardiovascular disease, and chronic kidney disease. Linagliptin did not increase hospitalizations for heart failure, even in patients at high risk of heart failure. Remember, at baseline, 28% had a history of heart failure. The overall safety profile, including kidney outcomes in this high-risk patient population, was reassuring. One can conclude that in this patient population, Linagliptin demonstrated cardiovascular safety for atherosclerotic cardiovascular events and a neutral effect on hospitalization for heart failure and kidney outcomes. Thank you for your attention. To close this